Okay, so today we are going to discuss about seizures, epilepsy and seizures. Okay, this session is included in the therapeutic guideline. Sorry, I'm gonna share my screen now. Okay, so here. Okay, so yeah. Here's the guideline. I already shared this guideline. If you want, you can download that file in the group, and you can make notes or highlight whatever you want to do. Yes. Yeah. So here, so what is epilepsy? So here, epilepsy is a disorder characteristic by tendency to experience recurrent seizures. The International League Against Epilepsy definition is disease of the brain defined by at least two unprovoked seizures occurring more than 24 hours and or one unprovoked seizure that and a probability of further seizures similar to the general recurrence risk. Like at least 60% after two unprovoked seizures occurring over next in 10 years. Diagnosis of epilepsy syndrome. These are the definition. You don't have to remember all of this, but remember this one. At least two unprovoked seizures occurring more than the duration more than 24 hours apart. Okay, remember this part. So, okay, 1 minute. I'll open my note as well. I had to find out. Give me 1 second. That's my seizure note. I can't find it in here. Something happened with my drive. Give me 1 minute. I'll figure it out. Okay, I found out. I still can't find. I don't know. Guys, doctors, give me 1 second. I had to find out it. Then I can easily teach you. Hmm. Yes, found. 1 minute. Yeah, sorry for the delay. I'm gonna show my note. Yeah, okay, so here the definition we all talk like two unprovoked seizures apart from 24 hours. Okay, this is the main thing you have to remember. Yeah, let's go one by one. Yeah, so like seizure mean it's a transient clinical event from the abnormal neural activity. Okay, and the epilepsy we already talked about, like two or more unprovoked seizures apart from 24 hours. The next one is status epilepticus. That means seizure is equal or more than 5 minutes or recurrent seizure without recovery. or more equal or more than 30 minutes carries the high risk of brain injury. You have to remember these mainly these two, epilepsy and status epilepsy
Hmm?
definition. Doctors, can you mute your mic? Yeah, that would be great help. So let's discuss about seizure types. Okay,
Do.
doctors, please mute your mic.
लगे ना मारे ना दीवारों पे.
Oh my God, who is mic is on? Yeah, okay, please keep your mic muted. Okay, so it's fine. Let's talk about seizure types. Okay. Yeah, doctor, I just did. Yeah, so seizure types we all know. In the TG, they have given a like cute table. They are given only main two classification. That mean focal seizures and generalized seizures. Okay, this is the TG classification they have given. I'll show here the classification of seizure. I made my note from this. Okay, so focal onset and generalized onset. Then, so focal onset again divide into, and we call focal seizures as partial seizures. Okay, they remember another name. And again, this can be divided into simple partial seizures and complex partial seizures. Simple mean the patient is aware during the seizure. Complex partial mean patient's awareness is impaired during the seizure. Okay, that's the division of the focal seizures. And generalized seizures, we all know it can be motor seizure and non-motor seizures. Usually, motor seizures are tonic-clonic seizure, seizures or myoclonic seizures. Okay, non-motor seizures are absent seizures. We will discuss each and everything one by one. Okay, so the same thing, and they have again given this classification as well. So generalized epilepsy, it can be idiopathic. That mean we all know here the non-motor and absent seizures are childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, epilepsy with tonic-clonic seizures on awakening. I don't have to remember all of this, but we will now just listen. I will explain one by one. Then you will understand what is childhood absence epilepsy, what is juvenile absence, what is juvenile myoclonic. Okay, I will explain the difference of these traits. Then focal one, it can be self-limited and symptomatic. Again, we divide into self-limited one and it can be symptomatic. Usually symptomatic one are the temporal lobe epilepsy. This is another topic we have to discuss. Yeah, other like other seizures are it's not, we can't classify it as full generalized, or we can't classify it as a focal. It's like both can be seen in here. Okay, so neonatal seizures, West syndrome, we know infantile spasm, right? Now these are the untitled. Wait, I'll show. I got there's a good diagram. This is also from Australian. This is from Australian Epilepsy thing Association or something, Australian guideline. I got this because of these pictures. Like can easily like memorize. So focal onset, generalized and unknown one, like that. Okay, the same thing. Yeah, okay, let's discuss what is focal seizures. It can start on our hemispheres, and it could be seizure. We can divide into aware seizure and means simple and complex, right? That means the patient is aware during the seizure. Okay, That means simple one. The patient's awareness is impaired during the seizure that we call complex focal seizures. Okay. Here the same thing they have mentioned. Here, yeah. Then generalized, it can be absence, the same thing. Yeah, here the same. And like, so tonic clonic mean what? What does mean tonic clonic seizure? Who can tell? In tonic clonic seizure, the body get a stiffness, right? The stiffened body, okay? The tonic phase, and then limb begin to jerk rhythmically. That the clonic phase. In the tonic mean stiffness, clonic means jerky movements, okay? That is how we call it tonic clonic stiffness and the jerky movements. Yeah. Then what is myoclonic? That means sudden single jerk of muscle or group of muscles that may last no more than second or two. More than a second or two. Like single jerk of muscle or group of muscle. It's a single one, myoclonic. So tonic we all know stiffness. Atonic, the brief seizure that causes sudden loss of muscle tone, and person often fall to the ground. Yeah, you don't have to remember this atonic, just remember tonic clonic, absence seizures, and myoclonic seizures. Okay, these are the type of generalized seizures. Okay, you don't have any questions, right? If you have anything, you just can ask. Am I going like too fast? Do I need to like reduce the fast lens, like slowly explain? Please tell me. This is okay, right? You all can understand, right?
Yes, ma'am.
Yeah, thank you. So here the unknown seizure that I told previously, we can't take it as either focal or generalized, okay? Like West syndrome. Mm, okay. So here, how we should diagnose the epilepsy. So in here, diagnosis clinical based on accurate description or eyewitness, or it could be a video. Okay, eyewitness or video, or usually we are diagnosing it clinically. They remember clinical diagnose. Epilepsy is a clinical diagnose. Okay. And EEG support diagnosis, but normal EEG does not exclude epilepsy. Okay, remember, EEG is a diagnostic method that can support the diagnosis. It is not the main diagnostic method. Okay, the diagnosis is basically clinical. Okay, MRI also can help to identify if there is a structural problem but does not confirm epilepsy. Okay. Yeah, then determine seizure type and epilepsy syndrome. Yeah, guide. Yeah, usually we have to determine the type because according to the type only we are like choosing the drug. There are several types of drug. We have to choose according to type of seizure. Remember, okay? You have to remember the type and the drug choice of the seizure. Okay, the same thing here. Okay, let's here's the here how we decide to treat the epilepsy. This is the algorithm we should follow. Okay, and before that, I'll read this one. So when to start treatment, like high recurrence risk after first seizure if the focal seizures, EEG, epileptiform changes, abnormal neuroexam or structural lesions on imaging. Start therapy after first seizure if the risk is high or based on patient's specific factors like he's a driver or like employment like that. We have to consider that. Okay. my God, doctors, please mute your mic. How to mute everyone? Hmm. Okay, thank you. Okay, mute all. Okay, I just muted, and if you want to unmute, please just ask, okay? Like type in the chat because there is a huge noises. Yeah, okay. So let's go through this diagram. I'll show this is therapeutic guideline diagram. Okay. You have to remember this one. Okay. The same thing I have added in simplest way because it's like a huge amount of details in here. So the first ever tonic-clonic seizure. Okay, so we have to investigate the cause, perform electroencephalogram. Okay, we have to investigate the cause and we have to perform the EEG, okay, electroencephalogram. So treat the cause if it is possible. Okay, treat the cause if it is possible. As example, if the patient has the febrile seizure, right, the cause is high fever, right? So, as example, we can treat the fever like that. Okay, then is recurrence risk is high, and or does the patient prefer to be treated? Okay, so when is the recurrence risk is high? When? I just showed you. Okay, here when is the recurrence? Recurrence risk is high in focal seizures, EEG, epileptiform changes, abnormal neuroexam, or structural lesions. Okay, here we can fulfill the recurrence is high risk high, recurrent risk high in below categories I just explained. Or does the patient prefer to be treated? The patients like drivers, in here they have mentioned like patient specific factors like driving, employment, right? So if the patient is prefer to be treated, if it is yes, if either recurrence factor or patient is like a driver or like other employment and that need to be treated, so yes, we have to then decide, was the seizure focal? If it is focal seizure, yes. So if it is focal seizure, we have to start carbamazepine. Carbamazepine, okay? The first line treatment for the focal seizure is carbamazepine. Okay, so if the seizure is not focal, okay, here no. The seizure is not focal seizure, so we can start sodium valproate. Okay, if we don't know the type or it is uncertain, so anyway we have to give sodium valproate. Okay, remember sodium valproate, like it's like wide gray, it has a wide coverage. Okay, that's why if it is not focal, we can give sodium valproate. Okay, here the next part is, if the patient doesn't have any high risk or is not the employment that need to be free from seizures. Okay, here's no high risk, he's not a driver like that. No, so we can observe because he doesn't have any high risk factor, so we can just observe. Okay, we can just observe, and if after observation, if during the observation he has a further seizures occur, okay, if he has a further seizures occur, then we can consider, if it is focal, we can give carbamazepine. Okay, carbamazepine. If it is not focal, we can give sodium valproate like that. Yeah, if patient doesn't occur any seizures during his observation period, we don't have to give any management, any drug. We can still observe. Okay, this is how we decide whether we should treat the patient or not. You all understand, right? Is there any problem or anything? Yep, okay. Good. You all understand. You have to just like remember this chart, okay? And the main thing is you have to remember the who are the high risk and who need to be who prefer the treatment, okay? Remember this, okay? Like that. Yeah. Then we have, okay, so we decided about the drug, and there's another table that how we decide the choice of drug. For when we decide, first we identify the factor. We identify the type. Okay, first we already identify the type. Then we have to think about these factors before giving the treatment, because anti-epileptic drugs has adverse effect, and they have some different kind of like I'll explain here. Okay, the factors affecting choice of anti-epileptic drug. So efficacy in treating the syndrome. Okay, we have to monitor the patient during the treatment. Okay, efficacy, if it is not efficient, or if the patient is still, as example, patient is starting a drug, and during the drug also he get recurrent seizures, so then we have to consider if this drug is efficient or not. That's here they mention efficacy of the treatment. And a certain syndrome diagnosis, if uncertain, consider drugs that are effective in focal and generalized epilepsies, like sodium valproate, I can't read this word.
Levetiracetam.
Yeah, Dr. Levetiracetam. Even in my med school, it's very hard to read this word. Lamotrigine and topiramate. Like these are like wide range of drugs. If it is not a focal epilepsy, or if it is uncertain one, we can give. But mainly remember the sodium valproate. Okay. So then female of childbearing potential and pregnancy. So it's during the pregnancy we have to consider more about these drugs, right? We all know most of drugs are contraindicated during the pregnancy, but lamotrigine has like a kind of good effect. So we will discuss it also as well. Okay. And male doctor, please, please, like remove this mark. Someone is drawing in my screen. Okay, how to remove it?
You can open your eraser and remove it.
Okay, wait. Okay, I don't know. Okay, I think it's fine. Yeah. Okay, so here the males of reproductive potential. If considering sodium valproate, a discussion about the potential risk of neurodevelopment disorders in children born to males taking sodium valproate may be appropriate. We have to consider, they have explained this, I'll explain then. And adverse effects, the body weight changes, impaired cognition, cosmetic changes. There's a good table I'll give you. It has like mentioned everything properly, okay? And the age, the is to use, need for like measuring the serum drug concentration, pharmacokinetics, and mainly we have to remember the drug interaction. Okay, remember this drug interaction. We will discuss it. Okay. Yeah, and yeah, the same thing. Yeah, here. So many factors are considered when choosing a most appropriate drug for the patient. We know the factors and we just discussed. So based on efficacy, the first line drug for this is from therapeutic guideline. The first line drug for the focal epilepsy is carbamazepine, and for the generalized epilepsy is sodium valproate. Okay. Yeah. So the same thing, I again mentioning the red color because it's very easy to identify. So the aim is complete seizure control without adverse effect. Okay, first line choice in focal epilepsy is carbamazepine. For generalized sodium valproate, and we all know we have to avoid during the pregnancy. Okay. And here, if syndrome is uncertain, okay, we don't know if it is can be generalized or focal. So in that case, we can use broad spectrum agents like valproate, levetrism, and lamotrigine and topiramate. Okay, like that. Consider efficacy pregnancy the same thing. Okay, and you have to remember a few more things about this drug and withdrawing. Okay, so here for these anti-epileptic drugs, we have to start at low dose, and we can increase slowly to the target. Okay, like especially lamotrigine, because the risk of severe skin reactions, Steve John syndrome, that's the main adverse effect in lamotrigine. So we have to start in low dose and then slowly increase the dose to the target. Okay, and fentanyl can be start at therapeutic dose or with the loading. If the first drug fails, add the second drug. Okay, that's why I told you we have to consider the efficacy during the treatment, right? We have to monitor, we have to like make a note, and we have to make a plan, everything like that. I will explain here. Yeah, I'll explain. Yeah, okay. So usually, if like again recurrent seizure can happen, we have to consider about the change into the second line drugs. Okay, so withdrawal must be gradual. If the patient is seizure free for 2 years, and then we can just think about the gradual withdrawal, like 6 weeks to 6 months. Okay, remember 6 weeks to 6 months is the withdrawal duration. Okay, driving not permitted during dose reduction and for 3 months after cessation. Okay, remember these points. How we start, like if what we are gonna do if the first drug choice fail, and how long we will take to withdraw. You have to just remember. Okay. Yeah. So how we should stop the anti-epileptic drug therapy. Okay, please remember this one. Consider stopping only after equal or more than equal to 2 years of seizure free period. You have to remember, okay, if the patient is equal or more than 2 years of seizure free, then you can consider of stopping the drug. Okay, but the recurrent risk is high with the with the symptomatic epilepsy, abnormal neurological exam, previous hard to control seizures, epileptiform EEG, abnormal MRI or CT. So like these kind of scenario, it's like very hard to stop the seizure drug. Okay, if we are considering of stopping, we have to wait at least 2 years of seizure free period. Okay, there should not be any seizure for at least 2 years. You have to remember these points. Okay. Yeah. So here the adverse effect. Okay, you should remember. Okay, you should remember these adverse effects. So fentanyl adverse effects are mainly HER2 system. Okay, mainly HER2 system. Acne cause facies or gum hypertrophy. Remember this like hug. Okay, HAG. HER2tism, acne, and gum hypertrophy. You have to remember these three mainly. Okay, these three. Okay, remember these three. I'll remember like hug, HAG hug. Okay, like that. These are the main three adverse effects. Then, then you have to remember carbamazepine. So in here, carbamazepine, we can see the hyponatremia, and other than that, you have to remember this one as well. Okay. So here in carbamazepine, we can see the agranulocytosis. Okay, remember they haven't mentioned in here, but I have seen they are asking in the recalls. Patient like who are taking carbamazepine with like low amount of WBs like that. So remember agranulocytosis as well. Okay. And for the sodium valproate, I have to remember weight gain, tremor, and alopecia. Especially remember this alopecia, okay? Alopecia, tremor, and weight gain, okay? Then lamotrigine, because of this rash, only we are starting from the low dose and uh, increasing slowly to the target dose, okay? Yeah, and gabapentin, weight gain, topiramide, they are not like mainly asking, but you have to remember phentermine, carbamazepine, valproate, and lamotrigine. Okay, you have to remember these three mainly. Okay, yeah, yeah. Then I'm just discussing each topic from here. Okay, they also have like here how we treat, like it's here. Same thing. Okay. Okay. Yeah, we are in here now. So, when to measure serum concentration of anti-epileptic drug? Okay, so drug efficacy for epilepsy is measured by clinical response to the anti-epileptic drug rather than its serum concentration. Okay. The serum concentration of anti-epileptic drug may be used to document the concordance with therapy or help to diagnose that symptoms or signs are due to toxicity or guidance of the dosage of fentanyl or adjust the dose of lamotrigine in pregnancy. Okay. We are measuring the serum concentration only in these scenarios. Otherwise, we can measure the clinical response other than the serum concentration. Okay. Oh. So the advice for the patient with epilepsy. So what are these advices? So practical information for the patient with epilepsy and the concentration, epilepsy, how we plan how we plan if the patient is already with seizure or patient with new onset seizure, like that we have to consider all of these. Okay. Yeah, the same thing. Okay, I have to remember this one. I'll show from my note. I think that is easy. Yeah, here the same thing. Uh, so practical advice for patients with epilepsy. So we have to advise patients to keep seizure diary, okay, and do not stop anti-epileptic drugs abruptly. Okay, we know the withdrawal time limitation is 6 weeks to 6 months, right? So we can't like suddenly stop the anti-epileptic drug. Okay, that can trigger the reoccurrence of seizures. And we can advise patients to avoid triggers like sleep deprivation, alcohol, stimulant, and stress. So we can advise to avoid these triggers. And drug interactions are common, and avoid dangerous activities like unsupervised swimming, because sometimes seizures can appear during the swimming as well. Okay, so yeah, these are the things, these are the advices we can give for the our patient. Yeah. Okay, so here one of important part is this one, contraception in patient with epilepsy. Okay, who can tell me about it? If the patient is taking anti-epileptic drugs and patient is already in oral contraceptions, patient.
We will increase the dose
Yeah, okay. So why we should increase the dose? Why? What is the reason?
because it increase the metabolism.
Yeah, that's why, right? So wait, yeah, here. Can't find it in here. Here, the same thing. Yeah, thank you so much, doctor. So, who are the? 1 minute. Doctors, give me 1 second. I'm getting a call. Yeah. Sorry, doctors. Yeah. What are these drugs? Who can tell me? Like, there's a huge bunch of drugs, inhibitors, and what are the other things? Inducers and inhibitors, like we know cytochrome P415, inducers and inhibitors. Do you know about the CRAB GPS? Okay, I'll show this one, then I'll explain. I think that also. Okay. You can easily remember about these inducers and stimulers. What is happening? Oh my god, why it is this one? Yeah, here. Where is that mnemonic? Here. Okay, you can remember these. Okay, so who are the inducers? Usually, cytochrome P450 inducers are, we call it inducers because these drugs can interact with other drugs and increase the metabolism, right? Metabolism of the drug and decrease the efficacy, right? due to the higher metabolism that can reduce the drug level and the efficacy in the blood. That's why if the patient is taking an anti-epileptic drug and she's taking oral contraceptives, there is a drug interaction and that can lead to the decreased efficacy of the oral contraception. Okay, in that case we have to advise the patient. Okay, we can advise patient she can use non-hormonal contraceptions like other one like except the oral contraception, other hormonal contraception or non-hormonal contraception we can give. Or if the patient still want to continue his oral contraceptions, we have to increase the dosage of the oral contraceptive. Okay, that's what you have to remember in here. So please remember this one. Okay, CRAB GPS. CRAB GPS here the carbamazepine, rifampicin. This is very high. They are usually asking from these P450 inducers. Okay, carbamazepine, rifampicin, alcohol, fentanyl, grisofulvine, phenobarbital, sulfonylureas, barbiturate, tetracycline, and quinidine. Okay, remember this. And there's other mnemonic for the inhibitors as well. What is that? Sickface.com. You want to see that one as well? Okay, I can show. I can't find it. I'll send it in the group. Do you have any other questions? Please be interactive, doctors. Today you are like very bored. Is it boring? Is this lesson is boring? I know
No,
some.
doctor, we are enjoying.
Yeah. Yeah,
We're enjoying the
because
lecture.
yeah. Yeah, because no one like neurology. I think, but I like neurology. Yeah, so that's what you have to remember, okay? Yeah, okay. So I feel like I'm the only one who's teaching and learning and doing everything. That's what I asked. Okay, that's fine. Good. Okay, so
Doctor, we are
contraception.
very concentrate on the lecture.
Yeah, oh, that's good. Thank you. Okay, so that's how we have to advise the patient about it. Okay, or if the as example we can suggest the patient about other contraceptions like IUD, ring, like those kind of thing. But if the still patient want to get the oral contraceptives, we have to increase the estrogen dose. Okay, remember this point. Usually they ask in this, and I think they have asked this point in June or July, can't remember. If I can find that recall, I'll share it. Yeah. Okay, so then pregnancy planning in epilepsy. Or we should plan the pregnancy during epilepsy. So here we have to consider the patient is pregnant, we have to refer the patient for the specialist. Okay, when planning pregnancy or patient is already pregnant. Okay, so major congenital malformation risk is 4 to 6%. So general.
Hello, doc. Sorry
Yeah,
to
doctor.
interrupt. Please,
Yeah.
is it the estrogen component or the progestogen component that is supposed to be
Estrogen
increased?
component, estrogen, doctor.
Okay, thank you.
Estrogen, yeah, we have to increase the estrogen component. Okay, so here the pregnancy planning. So if the patient is already taking the drug when he got pregnant, so we can't stop the drug. Okay, in this scenario we have to continue the therapy if needed. Okay, prefer monotherapy, use minimal effective dose, avoid valproates. Okay, we have to valporate unless there is a juvenile myoclonal epilepsy. I'll explain about it. Okay, if the valporate required, we have to use the dose as less than or equal to 600 milligram. You don't have to remember like everything. I just added because in TG they have mentioned. Okay, and we have to anyway give folic acid. Okay, before conception and during the early pregnancy, we know that. Okay, at
This
least.
for reproductive age humans, this criteria?
Sorry, doctor?
Is this criteria only for reproductive women?
This one, yeah, doctor. Here they have mentioned about the pregnancy planning, and if the patient is already the patient is taking drug and already get pregnant, like then we have to continue. Or if the patient is only planning, then we can consider this one as well. But it's not our duty. We have to refer the patient. Okay, when the planning pregnancy. The patient is already on the drug and she's planning the pregnancy, so we have to consider these criteria. Okay, because in juvenile myoclonic epilepsy, the main and the only drug we are using is valporate. Okay, that's why here we are considering this part. Okay, I'll explain during the juvenile myoclonic epilepsy. We all know like the patient has to take folic acid before the pregnancy, right? Okay, that's pregnancy pre-planning. One of thing is the taking folic acid. Yeah. Okay, so there's no questions. Let's move here. Okay, so here these are the medication and what comment during the pregnancy and breastfeeding. Okay, and safety. So here usually don't think about lithium here. Okay, they have given like everything here, including here the lithium and sodium valproate. Everything is here, anticonvulsants and everything. So here just focus on these two. Okay, sodium valproate contraindicated during the pregnancy. Okay, contraindicated during the pregnancy. So consider, but we can consider it safe for breastfeeding. Okay, remember, consider safe for breastfeeding, but it is contraindicated during the pregnancy, the sodium valproate. So carbamazepine, not recommended, increased risk of fetal abnormalities and neural tube defect. Okay, neural tube defect can be seen like neural thickness. So like that can be a defects, but there can be have some congenital defect, so that we are not recommended, not contraindicated, we are not recommended here. Okay, in breastfeeding women, high level in breast milk, so we don't have a good amount of data on safety here. So the best drug in during the pregnancy is lamotrigine, not contraindicated during the pregnancy. Okay, you have to remember. Yeah, so this table is common for everything. Okay. So here, anti-epileptic drug dose adjustment during the pregnancy. So lamotrigine level falls significantly. Adjust dose to maintain the pre-pregnancy baseline. So fentanyl and carbamazepine also decrease. So monitor, because uh, the valporate is the contraindicated one, but fentanyl is not, and the carbamazepine is usually not recommended. But some cases we can use that. They are mentioning in here. But the main thing you only have to remember lamotrigine. Okay, remember this one. Okay, lamotrigine. Okay, same thing. We discussed about the adverse effect. Same. Yeah. Okay, so Now the time is 8:52. We will take a 10 minutes break and we will do it again. Okay? What is happening?
Okay, doctor.
Yeah, so I have to get my charger and also, okay, let's meet after 10 minutes. Okay, bye bye. Hello, doctors. Hope you all are back. Okay, let's start next one. Okay, so I'm going to share my screen. So, who can tell me what is absence epilepsy? And this mean absence epilepsy. Who can tell me?
Which is sudden one, like without awareness.
Okay, so yeah, in here it's like in the word absence, like nothing, right? Here, this seizure is characteristic by sudden transient impairment of awareness. Usually, these patients are like daydreamers, right? I'll explain why, okay? In here, they usually begin in childhood and are part of the idiopathic generalized epilepsy. We discuss about absence epilepsy under the generalized seizures, right? So this is a part of generalized seizure listed as a childhood absence epilepsy and juvenile absence epilepsy. Okay, so absence epilepsy, two types: childhood absence epilepsy and juvenile absence epilepsy. Okay, I'll explain. So, clinical features. So, typical presentation is sudden pause in activity. Okay, there's absence of activity. That's why we call it absence seizure. Okay, sudden pause in activities is staring, like he's like looking at something and staring something, and he's like a daydreamer, right? That's what I call it, staring and unresponsive for few seconds. Abrupt onset and abrupt recovery, and no post-ictal confusion. May have subtle automatism like eye blinking and small movements can occur many times a day. Children often appear as a daydreaming, but episodes are too frequent and interrupt behavior. Okay, remember this one. Like that, loss of awareness, brief sudden staring spell or blank stare. So a complete stop in activity during the seizure, occasional nodding of the head, okay, small movement or eye blinking, still can see during the absence seizure. Okay, so according to the age group we divide, so childhood absence epilepsy mean onset usually 4 to 9 years. Okay, so 4 to 9 years. So juvenile absence epilepsy onset in adolescence from 10 to 15 years. Okay, remember these two. Childhood absence one mean usually 4 to 9. So juvenile absence epilepsy, the treatment and other everything is the same, but here you have to remember the age difference. 4 to 9 in childhood absence epilepsy, 10 to 15 in juvenile absence epilepsy. Okay, so both are listed under idiopathic generalized epilepsies. Okay, usually I'll show here. I have had this one as well. It's the same thing they have mentioned here. Okay, that's what I mentioned here. I have had the this is from DG. Yeah. So that's how we classify it, how we identify it as juvenile and childhood absence. Okay. So what are the triggers? It can be hyperventilation, sleep deprivation, stress, some medications like stimulants. So give me example for stimulant.
Cocaine.
Mm-hmm. Yeah.
Flashes of light.
Yeah, those are. And like when we call it like stimulant, you can you like what about ADHD drugs?
Atomizing,
Yeah, methylphenidate.
methylphenidate, and Release Dex or something. I forgot the name.
Dexamfetamine. Yeah, these two drugs are the stimulant drugs. Usually, mainly we use in like pediatric population, right? Because this is a pediatric case. So just remember, these are the triggering factors. So, and okay, so diagnosis usually this also a clinical diagnosis, okay, but in EEG we can see the classic 3 Hz spike and wave pattern. Please remember, sometimes in the questions they are given this part, okay. Yeah, please remember this 3 Hz spike and wave pattern. This one. Okay, so remember this word, okay? Spike and wave, 3 Hz spike and wave pattern. Yeah, and normal EEG does not exclude epilepsy. We know that part from the beginning, okay? The EEG means the supportive diagnostic, not the main diagnosis. Usually we are diagnosing this by clinically, okay? So then this for absence seizure, you have to remember the first line drug and the second line drug. So ethosuximide is the first line drug and the valproate is sodium valproate is the second line drug. Okay, I'll show. It's the TG. So here for the and absence epilepsies, childhood and juvenile absence epilepsy, the first line is ethosuximide, 5 milligrams per kilogram orally twice daily for 4 to 7 days, then increase 10 milligram twice a daily. Okay. Usual maintenance dose 10 to 20 milligram. You don't have to remember, just remember the name. Ethosuximide, and this is the first line, and sodium valproate is the second line. Okay, remember this. And we for to give sodium valproate, child should be older than 2 years. Okay, remember these points. Here the same thing, continue treatment until the EEG stops showing the 3 per second spike wave activity. Okay, we have to continue the treatment for these children until this spike wave has disappeared in EEG. Okay, stop showing this thing. And have not occurred for 2 years. We know we once we consider about the stopping the drug, we have to be the patient must have at least 2 year periods of seizure free time. Please remember this, okay, for your seizures. Okay. Then next one is juvenile myoclonic epilepsy. Okay, juvenile myoclonic epilepsy. Please don't confuse between juvenile absence epilepsy and juvenile myoclonic. Okay, juvenile absence epilepsy is usually in children. Okay, adolescent from 10 to 15. But this is the here, the juvenile myoclonic epilepsy is probably the most common for genetic generalized, genetic generalized epilepsy in adults. Okay, we all know juvenile is a genetic one, right? So remember that juvenile myoclonic one is the adult one, and the juvenile absence one is children one. Okay, just remember these two. And usually this can onset in late adolescent, usually 12 to 18. Okay, the onset time. Okay, it can occur from late adolescent to and continue during 12 to 18 years. The patient can appear first episode and then continue. Okay, this is the adult seizure time. So the typical seizure pattern is myoclonic jerk shortly after awakening. We know what is myoclonic jerk, right? I told you it's a single jerky movements of a muscle or a group of muscles. Okay. So may also have generalized tonic-clonic seizures. Some have absent seizures. Okay, this is the pattern. It could be myoclonic or generalized clonic-tonic seizure, tonic-clonic one, or sometimes can be absent seizures as okay. So triggers the same thing: sleep deprivation, stress, alcohol, early morning waking. Yeah. For that, okay, you have to remember for the juvenile myoclonic epilepsy, the treatment of choice is sodium valproate, sodium valproate. Okay, that's what I told in the during the pregnancy and planning pregnancy. If the patient has the juvenile myoclonic one, this is a genetic condition, so we have to anyway consider sodium valproate even though it is contraindicated, right? That's it. We have to refer the patient for the specialist attention. So sodium valproate most effective and often required for full seizure control. Valproate is the only drug that controls genetic generalized epilepsy such as juvenile myoclonic epilepsy. Okay, do you have any problem? You can just ask. Okay, so the same thing in here. I have like written down, typed here the same thing, okay? With the sodium valproate monotherapy in females of childbearing potential who do not have reliable contraception use sodium valproate 400 milligram orally. But in here, for adults, female who have reliable contraception or cannot have children, so we can use higher dose in here. Okay, like that. Discuss this part little bit earlier as well. So I'll explain the status epilepticus after 1 minute after this one. Okay, let's discuss about West syndrome. Okay, so what is West syndrome? Who can tell? Just on your mic and tell something. No one here to judge.
No, I don't know.
Okay, it's fine.
Rett syndrome is the infantile spasm.
Yeah.
Like occurs age 4 to 12 months and mostly usually in flexion but also in extension, and treatment is corticosteroid 10 milligram, I think.
Okay.
Okay.
So let's check. Okay. So what is West syndrome? Oh, we call it infantile spasm. So West syndrome is listed under epilepsy that can be focal or generalized. Okay. Can be under untitled category. It is a severe early childhood epileptic encephalopathy. So age onset usually between 3 to 12 months of age but peak around 6 months. Okay. So in here there's a clinical triad. Okay, there's a clinical triad. Okay, I'll show a picture. Here's the clinical trial. You can easily remember. Okay. Okay, here. So there's a spasm and hips arrhythmia in EEG and developmental problem. These three are the main triad of West syndrome. Okay, I will explain one by one. So infantile spasm, that means sudden brief contractions of neck, trunk or limbs. Occurs in clustered of often on waking. Okay. Then developmental regression, that mean developmental problem. Because why? the brain is not functioning normally, right? And the previous acquired development milestone start to fade rather than progress. That's why we can see the developmental problem. And the next thing is in EEG, we can see hips arrhythmia, chaotic high amplitude disorganized pattern like this. Okay, like this. So now I'm gonna ask some questions, okay, before that. So who can tell me what is the treatment of choice for focal seizures, generalized seizures, and absent seizures? Who can just tell me simply? Just tell me the first line treatment.
So
For
focal
focal,
seizures, first line treatment is carbamazepine.
You can continue.
Yeah, and for the absence, ethosuximide. And second line is sodium valproate, and generalized is for sodium valproate.
Okay. Yeah, that's good. You have to remember these things. Okay, so okay, let's move to next part in here. 1 minute. Here. So here we know the triad now, okay, and the time period you have to remember 3 to 12 months, and they usually peak around 6 months, and you have to remember this triad: infantile spasm, developmental regression, hips arrhythmia on EEG. Okay, you have to just remember these things. And here, okay. So this is the seizure description. Doctors, give me 1 minute, okay? I have to add TG diagram for the management 1 minute. Okay. Okay, done. Okay, so seizure description. This spasm, infantile spasm, can be in flexors, most commonly extensor muscles, and can be mixed. Okay, they tend to occur in clusters, separate by short pauses. Parents often describe them as sudden head drops, jackknife movements, brief stiffening episodes. Okay, so what are the causes here? So what are the causes of the West syndrome? West syndrome may be symptomatic due to structural, genetic, metabolic, infectious, these kind of problems, okay, or unknown cause, or the part of epileptic syndrome. Okay, just you don't have to remember everything, just I added because it's in the teaching. Okay, so diagnosis, usually clinical recognition of the spasm. EEG shows the hips arrhythmia, we know the triad. MRI recommended to evaluate the structural or metabolic causes, assess the developmental status, because 6 to 12 months babies developing baby, right? So what is in the chat? Yeah, doctor, thank you. Some doctors have typed in the chat. Yeah, so here we know usually clinical recognition, and we have to consider about this triad. Yeah, and that's all. So how we treat this infantile spasm or West syndrome? So what are the treatment? Prednisolone. Okay, prednisolone 10 milligram orally 4 times daily for 2 weeks. Okay, prednisolone. Or these two are first line drugs: prednisolone or tetracoxactide. Tetracoxactide These two are the first line drugs, okay? Either prednisolone or tetracoxatide. These two are the first line treatment, okay? First line treatment here. Oh, then the second line is vigabatrin. Remember vigabatrin. Third line drugs are clonazepam or nitrozepam. Okay, you have to remember predni or tetracoxatide as the first line and the second line as vigabatrin. Okay, remember these three. Yeah, who can just summarize the West syndrome? Okay, who can try? You just can try. No one here to judge. Just try. I'll help. Then you will eventually like understand everything and remember everything if you can. Okay.
So it's a triad of what? Spasms?
Okay, Dr. West
What
syndrome,
else?
you can like quickly, simply explain about the West syndrome, like a quick, short explanation. Okay, just you can try, doctor. Yeah, just give it a try.
Okay, so
Yeah.
the age is below 1 year, and it's
Mm-hmm.
a clinical triad of infantile spasms, what difficulty in gaining weight, the age, developmental problems, and the hips arrhythmias, and treatment is by steroid, the prednisolone.
Mm-hmm. Yeah, that's simply easy, right? Prednisolone and tetracoxatide, these two are the first line, and the vigabatrin is the second line. Okay, you have to remember. If you can remember, the third line as a clonazepam. Okay, so we did it. Yeah. So then, 1 minute, doctor. Actually, I can't find the charger somehow. Yeah, something happened to laptop charger. I searched everywhere in the home, but I can't find. I have to move to my iPad. Okay, give me 1 second. There's some kind of problem. Okay, doctor, I'm gonna wait. How long I can stay? Mm, Okay, give me 1 second. Sorry for there are so much delays today. Can understand. Okay.